Hello everyone, I am Dr. Anjali Gupta, a practicing radiologist from Agra, UP, with special interest in fetal imaging. Today, I will be speaking on the important role we radiologists can play in helping prevention of prematurity and its related complications. This is a part of the Samrakshan conversations regarding public health from the perspective of fetal radiologists. Samrakshan is the national program under Indian Radiology and Imaging Association with the aim to help reduce perinatal mortality in India. It involves a systematic phased approach in order to train and guide radiologists to work for a better perinatal outcome. It was developed by Dr. Rijo Matthew and launched by Dr. Hemant Patel in June 2019. Now, why is Samrakshan important in a country like India? In general, ultrasound and specifically fetal imaging is an often neglected area with emphasis and focus on cross sectional and body imaging, be it during the postgraduate training or in conferences throughout the year. We need to bring our focus back on various aspects of fetal imaging, otherwise, this branch will slip away from the hands of the radiologists into the fetal imaging specialists. For this, we require a platform with comprehensive training modules which is easily available and accessible to all radiologists throughout the country, and this is the core essence of the Samrakshan program. Coming to prematurity, the World Health Organization defines premature babies as those born alive before 37 weeks of pregnancy are completed. Prematurity can be subcategorized based on the gestational age as extremely preterm babies as those who are born less than 28 weeks of gestation, very preterm babies as those babies who are born between 28 to 32 weeks of gestation, and moderate to late preterm babies who are born between 32 and 37 weeks of gestation. Premature labor is the leading cause of neonatal mortality, that is, death happening within the first month of neonatal life, and the second most common cause of under 5 mortality the world over. To the right is a pie chart which denotes the estimated distribution of causes of 3.1 million neonatal deaths in 193 countries in 2010, and this clearly shows that preterm labor and its complications were responsible for approximately 35% of the neonatal deaths. Also, prematurity predisposes the neonate to infections, which in turn contributed to 25% of the neonatal deaths. Thus, the world over, more than 1 in 10 babies are born preterm. When translated to actual figures, this comes out to be 15 million babies per year in the world who are born too soon. Of these 15 million, 1 million deaths occur per year due to prematurity. Of the babies who are surviving, they suffer from severe immediate and lifetime disabilities in the form of respiratory distress syndrome of the newborn, cardiovascular maladaptation and neurodevelopmental delays, behavioral issues, learning disabilities, and hearing and visual problems, which entail a lot of emotional and financial burden for the families and the society at large. Now, if we come to the distribution of the preterm births, by virtue of the high population and the high birth rate, the South Asian and African countries contribute to around 60% of the total number of preterm births happening the world over. Of these, lower income countries have a slightly higher incidence of preterm births as compared to higher income countries. India, by virtue of its high birth rate, that is 2.45 crore births per year, the quantum of problem is very high. If we look at the distribution of the preterm births across various gestations, we find a ray of hope. We see that 80% of the preterm births occur between the 32 and 37th week of gestation, and these babies can be salvaged with good intranatal and perinatal care. Causes of preterm births can be broadly divided into three categories, that is, those occurring spontaneously without any known cause, that due to premature rupture of membranes and a very broad category of medically indicated preterm births. Onset of preterm labor is multifactorial. Maternal and fetal stress, especially conditions like depression, may lead to activation of hypothalamo pituitary adrenal axis, leading to premature onset of labor. Placental and cervical disorders, especially antepartum hemorrhage, also may trigger preterm labor. Various infections and premature rupture of membranes may also be responsible for premature induction of labor. Various maternal conditions like diabetes and pregnancy induced hypertension may trigger a sequence of events in which the baby might have to be taken out too soon. Also, nowadays, with increasing maternal age, couples are resorting to artificial reproductive techniques, which has shown an incidence in increase of multiple pregnancies, and as a result, due to over distension of the uterus, premature pains are initiated. Also, there has been postulated a genetic and immune dysregulatory mechanism for preterm labor. These factors are all natural phenomena which we don't have any control over. However, there is another subcategory wherein the fetus is unceremoniously plucked off from the mother's womb too soon because of iatrogenic reasons. Maybe the patient has had a bad obstetric history. Her fetus, her previous fetus succumbed at 38 weeks of gestation in utero, or she is experiencing loss of fetal movements. Both the gynecologist and the fetus have a big fear of fetal distress, or this is a precious pregnancy. Generally, in IVF cases, babies are delivered at around 35 to 36 weeks of gestation in a planned way in order to prevent late pregnancy mishaps. Another important cause is wrong dates. Maybe she didn't go to her radiologist at first in the first trimester. She never had a redating done. Maybe she remembered her. He didn't remember her LMP. Maybe she didn't bring her previous ultrasound records and came because of some conditions or some fall or some other medical conditions. The EDD was not reassigned in the first trimester at all. Also, many a times cesareans are planned to suit certain customs like a Shubh Muhurat or a marriage in the family or any upcoming festivals or just for plain convenience of the gynecologist or the patient herself. However, the World Health Organization recommends that induction or cesarean birth should not be planned before 39 completed weeks unless medically indicated. The World Health Organization in 2012 came up with a global action report on preterm births with the name of Born Too Soon, in which they have outlined the roles of the governmental agencies, individual social agencies, philanthropists, and healthcare providers in order to strive towards the goal of preventing the premature births from happening or to prevent its complications. Management strategies have been proposed at two levels. A. Steps taken with the aim of preventing stillbirths from happening. And B. If the preterm birth is inevitable, steps taken with the aim of preventing complications in the newborn. They have proposed a comprehensive plan wherein measures for prevention are instituted in the preconception stage itself in the form of preconception counseling, wherein the it is proposed that the patients are given sound advice according to their age and weight, their nutritional status assessed for any deficiencies, anemia corrected, in case of substance abuse by the patient, adequate counseling given for vaginal infections, and in case of history of previous pregnancy loss, a pelvic ultrasound offered to detect any uterine anomalies if any. Once she becomes pregnant, they have proposed that each pregnant woman gets at least 8 to 10 antenatal visits, including visits to the obstetrician and the radiologist for proper ultrasound examination. The WHO has also made provisions for adequate provider education in order to promote appropriate time of induction of labor and cesarean section in order to prevent the iatrogenic premature induction of labor. Also, once the pregnancy is over, the lady should also have better access to contraceptive use, and they also promote women empowerment so that the lady has the right for spacing between pregnancies. Once the new preterm birth is inevitable, they have given specific instructions for intrapartum and postpartum management in the form of timely institution of tocolytics for delaying labor, timely institution of corticosteroids so that the fetus attains adequate lung maturity, and magnesium sulfate administration in order to prevent cerebral palsy. If the lady has had PROM, then antibiotics are recommended to prevent infection in the newborn. Also, adequate provision they have recommended for neonatal resuscitation and management of RDS in the newborn. They also promote kangaroo mother care and frequent breastfeeding for the mother and the child. Also, if need be, comprehensive NICU care should be provided to the baby. With this background, we come to what contribution we as radiologists can make in this regards with the aim of a very better perinatal outcome. All these years, our main focus in OPS practice was the structural scan in the second trimester. We always thought that growth and environment was the prerogative of the gynec, just did biometry at spinal level. However, better understanding of the fetal environment and a targeted and a tailored ultrasound examination is the need of the hour. An optimum ultrasound scan is the mainstay of all obstetric management. The examination should start as soon as the patient lies down on the ultrasound table and is being positioned. Detailed and relevant history should be taken as regards previous pregnancies, any medical conditions in this pregnancy, and any genetic disorder in the family which might have a bearing on further course of the pregnancy. The first trimester scan is the most important scan as it establishes a reference point for assessing growth as the pregnancy advances. Care must be taken for optimum CRL measurement, in which the caliper should be carefully placed from the crown till the rump so that erroneous measurements are not taken. If the CRL does not correspond to the estimated gestational age according to LMP, then care should be taken to reassign the estimated date of delivery. Once the EDD has been reassigned, it should always be kept in mind that the pregnancy should not be redated in future examination. And in the second and third trimester, only this reassigned EDD should be used to calculate the correct gestational age at the time of examination. Also, care should be taken that the EDD should be reassigned only in the first ultrasound scan and not in subsequent scans, and never after 25 weeks of gestation. Also, care should be taken to not only do the NT-NB and structural scan and measure CRL, but also go ahead and do the uterine artery PI according to Samrakshan protocols and assess risk for development of preterm preeclampsia and FGR later on in this pregnancy. If you find that the risk is high in this particular pregnancy for development of preeclampsia and FGR later on, care should be also taken to mention that risk in the report as well as in the impression so that timely initiation of aspirin prophylaxis can be given to the patient. In the second trimester, it is always a good practice to look at the previous report and see if the scan was redated. In case the EDD was reassigned, then in this particular pregnancy, while entering the particulars of the patient on the machine, the corrected EDD should be entered and the machine will calculate the estimated gestational age at this particular date. Once you've done the biometry and the anomaly scan, then you should conclude your scan by doing the cervical length measurements. In case the cervical length is less than 25 mm, then timely progesterone administration, either vaginally or systemically, will go a great length in reducing the incidence of preterm labor in this particular pregnancy. Also, if you find that there is growth lag in the biometry, then you go ahead and do Doppler assessment, especially MCA and umbilical artery Dopplers. Once your Dopplers are over, then you address the uterine artery for calculating the PI and redefine the preeclampsia risk. In the third trimester scan, Samrakshan recommends Doppler assessment in all scans, irrespective of whether the gynecologist has asked for it or not. This will go a great length in the helping in timely diagnosis of fetal growth restriction, and also in staging of the growth restriction, so that we can be an active player in the obstetric management of such babies, and help in the follow-ups, timely follow-ups, and the timely delivery of compromised babies, so that we can avert adverse perinatal outcomes. In case preterm delivery is being contemplated for whatever reasons of staging of FGR or PIH, then we can also start timely corticosteroid prophylaxis so as to prevent respiratory distress of the newborn. Few things to be kept in mind for a good ultrasound reports are as follows. One should always look at the previous reports so that important relevant information is not missed while scanning this time. Also, in case of any abnormal findings, it is a good practice to check and recheck before giving it in your report. Also, all the relevant information should come in the clinical impression. The gynecologists are also busy people like us, and they do not always read everything which is written in the report. Rather, they look at the impression, and if they find anything amiss, then they look at the concerned section in the report. So, it is imperative that all our impression should be coming in the end of the report. Also, all the abnormal reports should always have a clinical recommendation in the end. That is, it's our duty not only to do the reporting but also provide an interpretation of what we found in our examination at the end of the report. For example, if the patient is stage 1 FGR and she is not yet 37 weeks of gestation, then our clinical recommendation would be to follow her up after 1 week, and so on and so forth. The role of the radiologist does not end simple at the scan and providing the report to the patient. Also, while for the 10 or 15 odd minutes the patient is with us at our examination table, we should be continuously talking to the patient, counseling her, and reassuring her. Especially if we find that she's in stage 1 FGR or there is a growth lag, we should counsel her about the signs of fetal distress and importance of kick count. And especially if in the scenario of reduced kick counts, she should timely report it to the obs-gynae specialist. Also, if she is in any stage of growth restriction, then not only we should we write the clinical impression and the recommendation in the end, we should also convey the same to our patient, so that in case the gynecologist does not call her after 1 week for follow-up, she comes to us herself. Also, it is very important that if the patient if the pregnancy has been redated in the first trimester, this should be conveyed to the patient that look, your fetus is smaller than what is projected by your last menstrual period, and you should also tell her by how many days. Suppose she shows a 2 week lag in the first trimester and you have reassigned the EDD by 2 weeks ahead, then you should tell her that please keep this in mind. In every subsequent examination, you should tell the radiologist, as well as every OBGY visit you should tell the OBGY that my fetus is smaller than what is projected by my LMP, Either this, or she should carry her whole clinical record with her every time she goes to the consultant. Also, not only the patient, we should always also be conversant with the obstetrician. Few obstetricians, it has been seen in my clinical practice that few senior obstetricians who don't keep abreast with the latest trends, they are not very particular about redating, so we can always talk to them about that. Also, there is a need for repeated dialogue stressing on the need for aspirin prophylaxis. In my practice, I see that either ecosporin is not administered to the patient at all despite whatever risk we give in our report, or if given, it is given in subclinical doses of 75 mg per day. So this also requires repeated dialogue with the obstetrician. Also, sometimes it is seen that even at 34 weeks, if stage 1 FGR is reported, the baby has been taken out by LSCS for fear of fetal distress. So again, if you feel that the fetus is in stage 1 FGR, a call to the gynecologist reassuring her that stage F1 FGR is not an indicator for immediate intervention, rather it is an indicator for timely follow-ups, is a good practice. Also, it is a good practice to always be in touch with a neonatologist so as regards the long term and short term outcomes of infants who are born prematurely, for better understanding and our own personal growth. Thus, the role of the radiologist is not only diagnostic but also preventive in the form of risk assessment in the first trimester and redating, and also therapeutic in the case of active stage based management of FGR. Thus, we should always strive towards striking a balance between fetal maturity and antenatal fetal health, and this is very essential for optimum timing of delivery with the view of good short and long term health of the born child. Thus, the radiologist is a very important key player in obstetric management. We are not just what our reports are, and our customer is not just our referring doctor but also our patient. Also, we have a responsibility towards the obstetric well-being of the patient under our care. Thus, there is a major need for paradigm shift from a passive approach of being a technician like provider to being a more active player in ops management. Thus, this is what the essence of Samrakshan is. At Samrakshan, we always focus not only on the structure of the fetus but also the overall growth and environment in which the fetus is developing. We also believe in giving a customized risk assessment to each pregnant woman according to her requirements. Samrakshan recommends fetal Dopplers for every pregnant woman, irrespective of whether the OBGY specialist has asked it or not. Samrakshan is involved in systematic training of radiologists, both at MD level and those who are in practice, by various online and offline CMEs and teaching programs which are mentor and peer driven. A lot of data is being collected from various districts across the country and analyzed for research towards creating standards specific for our population. The focus is not only on big cities but also on tier 2 cities and rural areas for pan India presence. Thus, I implore you to join Samrakshan and be a part of this very interesting and fruitful journey. In the end, I would like to conclude by showcasing a slide from the World Health Organization which states that everyone has a role to play to reach every woman, every newborn, every child, and to be accountable to reaching the poorest, reviewing information and accelerating change. Thank you for a very patient hearing.